it. Okay, great. Okay. Good evening. Welcome everyone to Evening Rounds. I really appreciate you taking time after work. I'm Dr. Edison. I'm a clinical associate in the complex gynecology and minimally invasive surgery section of obstetrics and gynecology here at UChicago. I specialize in hereditary cancer risk assessment and management. Beyond my clinical gynecology practice, I also see patients who have sort of known high risk mutations that we'll talk about, or maybe have otherwise a predisposition to usually breast, uterine, and ovarian cancer. So today's session will focus on inherited cancer testing and screening, where we'll cover sort of basic genetics, what the hereditary cancer testing process looks like, and then some benefits of testing and screening. And this is part of our continuing education series for OB/GYN nurses and medical assistants. So I'm going to just start sharing my screen. Okay. Do that. Right. And then let me know if it all looks okay on your end.
We are seeing double screen, so if you want to keep it
Oh,
that way.
double screen. Okay, maybe I don't. Um,
Now we're just seeing you. There we go. Okay.
Okay, let's see. And okay, how is that working?
You're still double screen, but it can work.
All right, let me try one more time, and then if that
Okay.
doesn't work, we'll just use the double screen.
Okay.
Oh, here, I think this will work. Okay, does that look
Yes, ma'am.
still normal?
You're
Okay,
good.
okay,
Thank you.
perfect. All right, great. Like I said, this is going to be a lecture looking at hereditary cancer testing and screening. So, we'll talk a bit about first, what are the basic genetics that you sort of need to know, how to identify patients as you're seeing them, either looking through results or even triaging them in clinic, what the process of testing looks like, and sort of basic management of abnormal results, so you get a good grasp on what the benefits and potential downsides might be to identifying these patients. So this is just a slide sort of going over again our vision and our mission statement and values here at University of Chicago. And hopefully I think that starting to find these patients and manage them individually really embodies a lot of that. So I have no disclosures. Like I mentioned, I'm a benign gynecologist. I work in our minimally invasive surgery section, and then I'm also a certified genetic counseling risk assessment provider. And on top of OB/GYN clinic, I actually work on the HEMONC floor Thursday mornings in our cancer risk and assessment clinic in 6B. And then that's my email. And for people who are putting in orders, the referral for us is just cancer genetics. So the objectives today are to identify patients with hereditary cancer risk, and this is going to be primarily looking at breast and ovary, become familiar with our genetic testing process, and learn the benefits of testing and enhanced screening. So we're going to go through cancer genetics, review the types of testing, and look at our management. So just a really basic inheritance review. So in all of our cells in the nucleus, there contains DNA, and that is essentially a blueprint containing all of the genetic information needed for development and functioning of us as a human being. Each of us have two copies of all of our chromosomes. So we have 23 from mom and 23 from dad, or 46 chromosomes total. And each chromosome is made up of genes, and these genes encode proteins. And so the proteins are what actually function. And that is about 20,000 genes total. So I like analogies. So if you think of all of our DNA as an entire cookbook, chromosomes are like the individual chapters in those books, or how the DNA is then categorized. And then within those chromosomes, you have our genes, and those are the individual recipes. And so recipes can make cookies, but genes make proteins. And so this is showing a karyotype, or kind of what our chromosomes look like, how all of our DNA is organized in all of us. So this is 46 total, two of each. And like you can see here that you get one from each of your parents. So what is a genetic mutation? So this is a change in the DNA sequence of really of a gene. It can be somatic, which is just a fancy way of saying acquired, or something that we gain throughout our life. So that is usually the result of either something random or potentially an environmental exposure. Things like, cigarettes is kind of the most common one. Even certain medications or cancer treatments can lead to these, or radiation. These kind of acquired mutations may not be present in all of our cells. So maybe just, for example, if you had chest wall radiation, there may be mutations just in your breast tissue, but not throughout, tissue in your legs or liver, and they can't be passed down most commonly. Whereas germline mutations are inherited. So it means that it came from either the sperm or the egg. And then it is present in sort of all of the cells of your body. And these are things that can be passed down from parents to children. Mutations can lead to a disease, or sort of a better way to put it is an increased risk of disease, especially when we think of cancer. So just because you have a cancer risk mutation does not mean that you are destined to get cancer. It just can mean that your risk of cancer is higher for that specific cancer than maybe someone else's. So I think this also shows it a little better. So, if you think of, you have a chromosome or a gene from either parent, and then for that gene to stop functioning, sometimes you have to sort of lose both copies, because it's sort of like you have a spare of each. So sporadic cancer, you may have one acquired mutation and then another acquired mutation, and that leads to cancer or tumor cells. Whereas with a hereditary cancer mutation, you already kind of come in losing one of these functioning copies. And so then it can only take just one more mutation to lead to cancer. So, for hereditary cancer genetics, kind of what is our goal, or what is the point of it? And if we find this, what is someone going to do with that information? So, it helps us predict a person's individual risk, and then also we can sort of risk stratify them. So, if someone is at average risk, they might just do standard prevention recommendations, yearly mammograms, no cigarette smoking, colonoscopies every 10 years. Where someone's at a moderate risk, maybe they don't have a very high mutation, but maybe we will do some increased screening, consider, breast ultrasounds or MRIs. And then if they're at a very high genetic risk, that's when we maybe even think about doing surgery. Is this someone whose risk of breast cancer is so high that we might do a mastectomy for them, or do medication, or do kind of additional imaging? So with our testing, what we're doing is we're actually looking at how this protein is individually encoded. And then when we find a mutation, we use that to create a risk, and then that risk gives us recommendations. So for hereditary cancer backgrounds, about 10% of cancers are genetic, but that changes. So certain types of cancer may be more likely to be inherited than others. So one example is ovarian cancer. That risk can be as high as over 20%, meaning 1 in 5 women with ovarian cancer potentially have a high risk mutation. And if they had known about it, we may would be able to prevent it. The same goes for triple negative breast cancer, or things like male breast cancer. It's lower for others. So when you see a patient with cervical cancer, that is almost always, more than 95% of the time due to HPV infection. So that is not genetic. That is something that they picked up and acquired. And risk can be higher for certain ethnic groups. So, one group that we commonly talk about is Ashkenazi Jewish population, which are Jewish patients usually more with a European ancestry. And these patients have as high as a 1 in 40 chance of a BRCA mutation. And we'll talk a little bit more about BRCA. Versus someone in the non-Ashkenazi average population, that risk can be as low as like 1 in 400. So, when to suspect a, hereditary or inherited cancer if you're talking to a patient. So, if a patient has an early onset cancer, so, someone with breast cancer at 70 may not really kind of raise our eyebrows, but someone who has breast cancer in their 30s or 40s will. Same with uterine cancer and even colon cancer, sort of about that same age. Once you're getting less than 50, we're wanting to sort of think about, could there be something else going on here? If patients have bilateral cancers, it's obviously typically with breast cancer that we're thinking about it, or an individual who's had multiple cancers. If you're talking to a patient and it seems like multiple family members or generations have had cancer, especially the same type. And so usually I think of that as like once we're getting to about three family members, then I'm really thinking this is someone who probably should meet with genetics. Certain cancers, certain mutations, as you'll see, kind of come hand in hand with certain types of cancer. So the same mutation can increase the risk of colon and uterine cancer. So if someone's like, well, my grandfather had colon cancer very young, and then my mother had young uterine cancer, that's someone who also should be seen. Rare cancers, like we mentioned, male breast cancer, populations we already talked about, and then you may or may not, I think maybe nursing staff on the call may be a little bit more familiar with this, but you may see genetic testing on tumors, and that's when they're actually looking at the tumor DNA. And that oftentimes is just kind of changes that have happened within the tumor. But there are some mutations that can show up in the tumor that we think, oh, this may be present actually in every cell in the body. And there's certain ways that that physician might identify that and then pass that patient on to us. So how do we evaluate them when we see them in our hereditary cancer clinic? So we take a personal history, so looking at risk factors or exposure. So if someone has a lot of melanoma in their family, but also has fair skin and has had a lot of sun exposure, that is something that we'll take into account. And then we take a really detailed family history, and usually we're sort of looking back. Um, about four generations. So their kids, but more importantly, their siblings, their parents, and their grandparents, because usually their children are too young to know if they're affected. And we draw actually one of these little maps out of their family. And so as I mentioned, we'll talk a little bit about the BRCA mutations, but that is kind of the first real gene that was found to be associated with strongly with cancers, mostly breast and ovary cancer. And so for this patient, we have a little arrow pointing to our patient. She had a mother with breast cancer in her 40s. So again, that's less than 50. That's concerning. A grandmother with ovarian cancer. And ovarian cancer, really anyone who has ovarian cancer in their immediate family should be tested because it's so likely to be genetic. As well as an aunt with ovarian cancer. And then she also had a cousin who had breast cancer in her 30s. Um, this also may show, not everyone who has the mutation will have a cancer. So, it skipped a generation here for her cousin. Her dad has not yet been diagnosed with a cancer yet, although he is at some increased risk for other cancers. So sometimes if, it's a grandmother and a cousin, that still would worry me, even if her mother wasn't affected. And then the testing process, usually it's either a blood kit if they come to see us in the office, or we can send them a saliva kit at home. Very rarely we actually do a biopsy of their skin and look at the skin cells, and that's usually for patients who have certain types of ongoing cancers already. So that's not really common. In terms of our testing methods, so we used to just kind of look at maybe a few genes or the gene we thought was most likely. But now, as testing has gotten a little bit easier, we can test for multiple things at once. Mostly, we're doing what are called multi-gene panels. So, someone may have a family history of breast cancer, and we may test them for, 20 to 30 genes associated with breast cancer. And so that gives us feeling like we're getting a good assessment of them. And these may even test for different cancers as well. So maybe she has colon and breast, and so we may add colon cancer genes as well as breast cancer genes. Sometimes someone will come in saying, I know my mom has this mutation and I only want to test that gene or that specific mutation, and we can do that. But sometimes we worry that we may be missing something. And then there used to be, and you can still use them, but they're a little bit less common, founder mutation panels. So, for example, if you were Ashkenazi Jewish, then we would only test you for the mutations most associated with the Ashkenazi Jewish population. And in terms of how this works, we do something called next generation sequencing that essentially chops up the DNA and then helps to sequence kind of multiple genes at once. It's fairly fast and it's cost effective, so it's not like you're having to do one thing at a time. The downside of kind of looking at all of these genes and looking at them sort of very completely is that you might get a lot of variance, and we'll talk about what those are. And we might find things that we don't really know what to do. And you may find mutations and things that you weren't even having on your radar and that there's no family history of. And those can be difficult conversations to have with a patient. So, in terms of the possible results, so you can get a positive, meaning we know that there's a mutation that impacts the way that the gene or the protein would work and can increase your cancer risk. You can get a negative, meaning that, based off of your personal history, your family history, and what genes we know to test for, we haven't found anything concerning yet. That can be helpful, although sometimes if they have a strong family history and everyone's tested negative, we sort of still have to treat them as if we think there might be something there. We just don't know how to test for it yet. And then you can get these other variants of uncertain significance, which means there may be, a mutation or a quote unquote typo in the DNA, but the protein may still function or it may not, and we're not sure. And so then we have to tell them, well, we don't really know yet if this is going to increase your risk or not, and we'll have to follow it over time. And this is just an example of a genetic result. So this is showing someone who had a mutation in the BRCA2 gene. It actually tells you exactly what that mutation is, where in the protein you would sort of see the problem arise. And then they talk about what the genetic risks are associated with this mutation. So, what are the benefits of doing this testing? So, you can provide a specific cancer risk, and well, that's great. But if someone tells me that I have an 80% chance of getting a certain type of cancer and there's nothing I can do about it, what am I going to do with that information? And so, usually, we're testing for things that we can actually prevent or screen for, or reduce the risk of. And so, we can say, well, if we did nothing, your risk may be 80% of breast cancer, but if we put you on the screening regimen, if you do a mastectomy, if you take this medication, we can significantly lower that risk. It also can help provide an answer and decrease anxiety if patients are seeing, multiple family members die of a mutation and then they get a negative answer. That can be fairly reassuring that that's something that they don't have to worry about specifically for themselves. It provides prevention strategies, like I mentioned. And then, someone may see you who's had that cancer, and it might be sort of too late for this mutation or this diagnosis to make a difference for them, but it may be a way that they can feel like they can prevent their sister or their daughter of going through the same thing. The downsides are, like I mentioned, when you get a negative result, it can be a little bit unclear as to what that means. Is this person not at an increased risk, or is it that we just don't know yet what that gene is? Because we're still this is a field that's sort of changing year to year. Those variants of uncertain significance can make patients quite anxious, although usually we have some information to sort of hedge our bets and say, based on where this mutation is and how things were kind of substituted, we're not so worried or we are worried. Some people actually have, yes, obviously, families can be complicated. And so discussing this with family members, especially if there's some difficult dynamics or estrangement, can be hard because there's sort of a legal imperative to inform your relatives that they may be at risk. There's the cost of testing, although we do have some nice ways to sort of help with that for patients. Some patients will find that this actually increases their anxieties. And then I think, especially in this age of kind of a lot of information being out there on the internet and data leaks, patients get very concerned about genetic discrimination. If my employer thinks I'm going to get cancer, or if my health insurance company thinks I'm going to get cancer, is that going to affect their ability to insure or hire me? There has been a Genetic Insurance Non-Discrimination Act passed where you can't use mutation status for employment or healthcare insurance purposes. However, it hasn't yet been covered in terms of life insurance. So if you do have a high risk mutation and your life insurance company were to find that out when they were assessing you for insurance, they could take that into account and either not cover you or make you pay a higher premium. I haven't come across that happening yet, and we usually tell patients who are concerned about that to, maybe sort of get their plan in place before they do testing. So this is sort of an example of cancer risk. So BRCA1 and 2 are the two most common genes that people think about when they think about an increased cancer risk. And so usually these are for breast and ovarian cancer. And it's just showing you how high these risks can be. So if you're, an average person, your risk of breast cancer is about 12%, meaning, 12 in 100 women will get breast cancer versus if you have BRCA1 or 2, that risk is as high as 70 to 80%, meaning, much more likely than not, you're going to experience breast cancer within your lifetime. The risk of ovarian cancer with these genes is also much higher. So ovarian cancer for the average person is only 1 to 2%. So 98% chance if you don't have one of these mutations, ovarian cancer is not something you have to worry about. On the other hand, if you have BRCA1, that risk can be as high as 40%. And, that still means that more than half of the time you may not be diagnosed, but it's getting pretty close to half the time. And ovarian cancer is not like breast cancer. It's harder to find early and it's harder to treat and cure. And so we're very sort of aggressive with these patients in terms of prevention, even though their risk maybe isn't as high as the breast cancer risk. And so for BRCA2, the ovarian cancer risk is a little bit lower, but it still is as high as almost 20%, meaning 1 in 5 patients. There's also some maybe increased risks in male breast and prostate cancer, and then also some increases in pancreatic cancer. And there is some studies looking at screening now for pancreatic cancer as well. So, what do you do if you have a patient who comes back and has either a high risk mutation, usually meaning 40 plus percent, or sorry, for breast cancer above 20%, or a moderate risk where maybe it's above 15% versus average risk. So, for breast screening, the average person, as you probably all know, we recommend an annual mammogram or at least every 2 years, beginning at age 40 with a clinical breast exam. A moderate risk patient, you will often still get your regular mammograms. If it's young in your family, you may start a little bit younger. And we may be a little bit more likely to add on additional imaging, especially if you have dense breasts. At a certain point, you may also be eligible for tamoxifen, which is a medication that can actually decrease your risk of breast cancer by about half. And then if you're in that high risk group where your personal risk is above 20%, that's when we're doing annual MRIs and we're starting early, sometimes as early as 25, as well as an annual mammogram. Patients who have a known mutation where their risk is maybe more than half, they can consider doing a mastectomy as well, but they don't have to. And then we also may talk about tamoxifen with these patients. For ovarian cancer, unlike breast, we don't have great screening, we don't have great treatment, and not great prevention. And so besides surgery. And so surgery is really the kind of best option for these patients, and that means removing the tubes and the ovaries. And so for BRCA patients, we recommend this as early as 35, and for BRCA2 as early as 40. And then there's some other genes as well that we do recommend ovarian removal from. Some of these actual numbers I think have changed a bit over the years, and that guidelines sort of come out every year, but these have stayed relatively stable. The other thing we think about are actually birth control pills. So 5 years of pills can reduce your ovarian cancer risk by about 40%. So that's very great for some of our younger patients. And now we're also looking at some studies where we remove just the tubes first and then come for the ovaries later to avoid putting these patients into really early menopause if we don't have to. Besides genetic testing, where we actually look at your DNA, there's other risk assessment tools we can use. There's a lot of calculators. The most common one is probably that you'll see the Tyrer-Cuzick for breast cancer. And that's actually a lot of times listed on the mammogram results. So if you're a nurse on this call and you're looking at a mammogram result and it says the mammogram is normal, it may also say this patient's Tyrer-Cuzick is elevated, estimated above 20%. That's something that really we should flag because this patient is eligible for MRIs. They may or may not want to do genetic testing to make sure they don't have a mutation. And it is usually listed out there. If all of your genetic tests are negative, certain companies that we do screening with will actually give you a risk score. So they'll look at your family history, your personal lifestyle, things that could increase or decrease your risk, and then certain small changes in your DNA and give you a little bit of a better personalized score. And so we use that especially for patients who have a strong family history of breast cancer. It hasn't really been developed yet for other types of cancers. And then this is just showing that there's, a lot of these calculators out there. So, like I mentioned before, these are how we manage our moderate risk and high risk breast cancer patients. This is sort of the best link that I have for the Tyrer-Cuzick score, and it looks at things like when was your first period? Are you in menopause? When did you have your first child? Have you had a breast biopsy? Those types of things to give you a lifetime score. And then this is a link for the Wisdom study, which is a free study that anyone can sign up for. I'll have the actual URL at the end, and they will ask you about your family history. They will send you a genetic test in the mail. They will test you for the major breast cancer mutations and give you a risk score at the end. And it's kind of looking at, is this something that we should be doing for everyone? Is just telling everyone to get an annual mammogram not good enough? Should we each be getting our own score and then deciding, maybe your score is really low and you only need a mammogram every 2 years and you can save yourself that radiation, or your score is really high and you probably should be starting earlier and getting something additional besides just an MRI. And this is completely free, which is wonderful. So, in terms of lifestyle recommendations for breast cancer that really everyone should follow, but especially these are what we talk to our high risk patients about. Unfortunately, it's nothing probably new. So, weight, especially high weight after menopause, can be linked to an increased risk of breast cancer. And that's because fat cells can make estrogen, which can stimulate the breast tissue. There is maybe some evidence that people that are underweight may also have an increased risk of breast cancer, although I don't know if we know the reason for that yet. The number one thing that sort of we have control over besides our weight is actually alcohol use. And so even though we say women can have a drink a day, even above 3 to 4 drinks a week, we start to see the risk of breast cancer increase. And so it's estimated about a 10% risk per drink per day. So especially my high risk patients, I talk to them a lot about that. Cigarette smoking, breastfeeding can also help reduce your risk. So it's about a 4% reduction per year of breastfeeding. So not a lot, but if your risk is 12 and you breastfeed for 2 years with two different kids, then you're getting that risk down to way less than 10%. Physical activity and low fat diet have been also linked to a lower risk. And then patients, may ask about hormonal birth control. If I'm taking birth control pills and potentially even other forms of birth control like the IUD, does that increase my breast cancer risk? The answer is probably if you're on it for more than a couple of years, especially if you start it very young, it probably does increase it slightly. But we're always trying to balance this with other benefits. So if someone has really severe endometriosis, or if they're at a high risk of ovarian cancer, we're trying to prevent uterine cancer. These are all things that the birth control can be helping with. And I think, especially for breast cancer, while it's important to lower our risk, we do know that we have good screening and we do know that we have good treatment. And so, it's worth a discussion, but it doesn't mean that you have to necessarily stop it. So in terms of our team approach to care, so I was sort of thinking about the best way to incorporate this knowledge to empower you all when you're seeing and talking to patients. And so if you're an MA seeing a patient, I think every provider is a little bit different about how much they want you to get into the history, but asking about cancers in the family, especially breast, uterine, and ovary is really important. Recognizing, sometimes I'll notice on a patient's family history, it will say mom, aunt, cousin, all with breast cancer, and it's probably been there for years and no one's talked to them about it. So noticing that too, and maybe just flagging it for the provider, like, hey, just so I know, just so you know, I noticed there's a strong family history of cancer. And then, if these are positive, then that sort of can go up to the provider to ask follow-up questions. What age were these people? Have they had genetic testing? Those things that would really help decide, do they need a referral to us? In terms of nursing, I think, it also depends on where you come into contact with the patients, but I know probably a lot of you do see our mammogram results. And so noticing breast cancer risk on mammograms can be helpful because that can definitely slide by us. So noticing elevated tyrocusic scores where patients have a lifetime risk, especially above 20%, to saying, hey, to the provider, sometimes these aren't accurate, but maybe this should be more formally looked at and recalculated because they may need MRIs. Again, recognizing when patients have multiple cancers listed in their family history, and then being aware of the wisdom study and cancer genetic referrals as potential resources for patients. In terms of cost, I also was just going to mention that so the wisdom study for breast cancer is free. Cancer genetics, so we look at patients who've had a lot of different types of cancers in their family, and a lot of our um, screening options will either be covered by insurance or the companies we use may have an out-of-pocket max, and we'll call the patient before running the test. And usually that maximum is capped at around $200 or less. So that still can be too much for some of our patients to pay, but it also is not, like you're going to get a surprise bill for thousands of dollars. They make sure that you're comfortable with it. And then if you're positive, a lot of companies will do sort of free testing for immediate family members within a certain amount of time. So if someone does test positive, that means that we can get, her sisters, her children in sort of right away to be tested, and that would be free of cost. And that is all I have for you. So, like I mentioned, the referrals can go to Cancer Genetics. You can always email me here too if you have a patient that you're concerned about who you think needs to see us. And then for pretty much everyone, but especially if you have someone that's worried about a high risk of breast cancer, the wisdomstudy.org is a great way to go for free testing and recommendations. And then I'm going to just open it up for questions. Thank you. Okay, well, if no one has any questions, I can give you guys back some time, but please feel free to email me. And really patients who have breast cancer less than 50, ovarian cancer or young colon cancer in their family, definitely, maybe let the provider know or ask them if they've had genetic testing because it can be very helpful for them. All right, thank you guys. And Joanne, is there anything else?
Just the next session will be on November, sorry,
Third.
the 3rd.
Yes, I have it. Yes,
Okay.
with Dr. Lee, and she's actually doing gynecologic cancer. So it's, I think, probably a nice tie-in to this lecture.
Yes. Thank you again for your time.
Okay, great. Yes, of course. Okay, good night.